others off?
No, this is all producer problems. This is all my fault. It's all right. Hi, everybody. We're live. Just in case you were wondering, we're just chatting. No, this is all I need to work on. I need my AI agent, podcast producer person to book more guests. But hey, we always have fun conversations. So it's always good.
No problem.
Yep, let's do this. All right, we're going to talk healthcare, real estate. Well, healthcare trends and that affect real estate too, also, right? Some weird things that are going on. But Deanie, go ahead and introduce yourself to the audience here and all of our.
Deanie Taylor, CEO at Landmark Healthcare, private outpatient medical development company. We develop across the 48 states.
Awesome sauce. Awesome sauce. And I'm Amy Palvido. I'm your host. I do these shows every once in a while, like a lot. And I am the CEO of Facilimax and the chairwoman of the United States PropTech Council. Woo woo! And for those of you who are interested, we are having our very first event at South by Southwest on March the 9th. It's happening, y'all. It's happening. So we'll have tickets up for sale on the website today. So if you happen to be in Austin, Texas on March the 9th, come by. We'll love to have you. All right. Let's talk about this whole, I think this is funny. I think this is funny because it's like this TV show that I used to watch called Hank Med. Do you remember the Hank Med show? Okay. No. So it was concierge medicine.
Oh.
And they were in the Hamptons. So this, burned out ER doctor trying to do the right thing, gets booted by the hospital because he chose one patient over the other patient, and the other patient was like a donor to the hospital's son or something like that. And so he should have not done, whatever, blah, blah, blah. Bleeding heart ER doctor chose the the black kid over the donor's rich white son, whatever. Anyway, so I know way too much about that story. And anyway, so he goes to the Hamptons and he starts doing concierge medicine. Right. And then look at that. They took a script from that TV show, and now concierge medicine supposedly is booming. I love these headlines because they're crazy town. And New Yorkers are willing to pay almost anything for the privilege. So does concierge medicine replace medical office buildings? I'm just totally kidding. But does it make an impact?
It doesn't replace the real estate. The doctors have to still be in a building. But I would agree. I've used concierge physician for 7 years now. And,
really?
In Florida, in Naples, and I worked with several in Indianapolis. It is an alternative for those who can afford it. And it's not near the pricing. It's market specific, the pricing. I mean, obviously New York, they can charge whatever they want to charge because people can pay it.
Exactly.
That want a concierge physician. But I mean, if you think about wanting a physician who is readily available, that you don't have to worry about getting an appointment, that you can get a call back directly from the physician, that you can text or email back and forth, depending on what information needs to be exchanged. And they will still accept insurance if your insurance covers something, but you pay a fee, an annual fee. And it really gives you access to a physician. And then these physicians have lots of referral contacts for other specialties because the other specialties like working with a concierge physician. Right. Typically is an internal medicine physician or general practitioner or family practice. I mean, and I've never had a problem getting to a specialist. They tend to have good relationships with hospitals. So it works. I mean, they call to remind you about things. I mean, I get a little, it's a little obsessive about flu shots and all the vaccines and all that, but they do not let you forget.
Interesting. So so you pay an annual fee for this?
I pay an annual fee,
Okay.
and you sign a contract that kind of outlines exactly what services you'll get.
Mm-hmm.
And like I say, I've seen it in Indianapolis and in Florida. The fees are different by
Yeah.
market, and
Yeah.
then with this article in New York, the fees are very excessive. But I mean, it's New York.
I know it's New York. So it's not necessarily that they're coming to your house, or they are coming to your house. No, it's just accessibility to a doctor when you want accessibility to a doctor.
Right. And you can, I mean, I have called at night and been able to see the physician the next morning.
Okay.
But he'll answer the phone at night.
Interesting.
I mean, you have a cell, you get his cell phone, and that's typically how all of them work.
Interesting, because I remember way back in the day, you didn't have to pay for that, because there was always an on-call physician. So especially my pediatrician, I could always get a hold of a doctor if something was wrong with my kid at my doctor's office. I just put in a phone call. They call right back and they go, tell me what's going on, and I'd be like, this is what's happening.
Now it's usually a nurse practitioner, maybe, not the physician. And the other thing is, if you are relocating to a new area, it's hard to get in and find a physician. And so a concierge service or a concierge practice is a good way to do that.
Yeah.
But once you're their patient, they really take care of you. And there's a limit to how many they take. I mean, it's not like they just keep filling it up.
Sure.
Because they manage. There are 4 physicians in the practice that I go to, and one of them is my concierge physician.
Interesting. So but they still have offices. They still have everything. Yeah.
And they have all of the typical services, lab and X-ray, all that kind of stuff. I mean, and those charges get billed to the insurance.
Okay.
When I go in there and they do lab work, they charge the insurance. I'm not paying an extra fee over and above the fee I pay annually, and they accept whatever the insurance pays.
Interesting. Okay. Well, all right. So they're not going to show up with the truck with
no, this is not house calls on steroids or anything like that. There are services like that. I'm not familiar with them, but
interesting. Okay.
These physicians are in offices. It's not going to hurt the real estate at all.
All right. So it's actually maybe it just comes a new form of care. I mean,
Well, I would tell you, I believe, as it relates to real estate and the ability for physicians to pay rent, by them receiving fees or annual fees, they're more likely to be able to pay because they're not in a cash flow situation with insurance.
Yeah, for sure.
And I think it's a better thing.
Revenue. It's the monthly revenue or yearly revenue. It's like the golden model of every software company that gets subscription revenue every month. Taking cash flow. It's great. Right. Yeah. It's really kind of interesting. I think this goes back to one of the other articles talking about how the doctors, the multiples ways of getting paid, they feel more financially secure. Well, duh, of course. Right. If you have 7 streams of income, but I don't even know if it's that, but the patients are paying, how they're getting paid, right? What insurance company it is, or is it Medicare or is it Medicaid? I remember back in the day, some doctors wouldn't take some forms of insurance, but they just took forever. Right.
Right.
But, which I feel, I was a general contractor, and some of my clients would take 90 days to pay me. That just kills you. It kills your company. And so,
right. And I think that is referencing that other article you're talking about. Physicians that have multiple sources of revenue, there's a high likelihood they can manage their cash flow better, because it is not unusual for some of the commercial payers to be very slow paying. And so you've got to have other sources of payment. So physicians are figuring that out. And it's helping them on a cash flow basis.
Yeah, for sure. Is there a magic number? Do you know? Like 6, 7 magic numbers?
I don't, I think it's, my guess is, and I'm not in the practice, but my guess is the number is dependent on how many different programs they can manage,
Right.
because they may have different rules and qualifications to get payment, and so there's a limit to how many they can manage. And if they are Medicare and Medicaid providers, many times that's 30-40% of their business. So it becomes difficult to manage if you have too many.
Yeah, I anytime I read articles like that, I'm like, there's going to be an AI solution that comes out and solves this problem. Like anything that's like super complex, but it follows a pattern, like a logical pattern, just put an AI agent on it and automate it. And, but in all those, I'm sorry, all you medical coders out there, you probably should go back and learn another skill. Because I just think that they have AI now doing note taking for doctors, and there's like a new AI company that just got this round of funding, like $150 million, like CVS Health and somebody else, their venture arm, because the AI is doing all this note taking and documentation and all this other stuff for doctors. And so AI, that was, oh my gosh, I'm way back in the day. That was one of my jobs, Deanie. Back in college, I would have to listen to these headphones, and it was a psychiatrist, and I would have to type out their notes. This is one of my college jobs. And I'm sitting there and I'm like going, and some of the psychiatrists could like dictate well, and someone would mumble. I'm like, what the hell are you saying? How do you expect anybody to type this crap out? Because like, this is horrible.
And today, if that's not done well, you don't get paid.
Is that what it is? Yeah.
If those notes aren't correct, then chances are the code won't work, and you won't get paid.
Interesting.
But I agree with you. I think AI has a role to play in this, and could likely speed up approval or denial, depending on whichever way it goes, for various procedures, instead of getting caught in kind of the process that physicians and insurance companies use. And it's frustrating to physicians and definitely to patients to wait to know. So I think AI could play a big role in that.
Yeah, I find it interesting, even if it's just the first pass, right? You'd always want to have a human kind of oversee certain things, right? But even if it's just the first pass of like maybe 80% of the whatever, and then you have the we don't know thing and have a human kind of look at it. But I just kind of see it now, and the stuff that we're building and the automations we're building, why couldn't you? I mean, you just need to have somebody who's trained in that, any like reading MRIs and reading whatever, and they're looking at it's this and this and it explaining it. I mean, it's going to be pretty interesting to see what happens in the next couple of years, right?
It will be.
Yeah.
And then there's the whole regulatory side of being certain that someone is passed various procedures and rules that allows all of this, because that overrides all of this in the medical field. So it'll be interesting, because it'll have to go through some review process, and somebody will have to approve it. And whether that's state or federal, and all those things will have to be done.
Yeah. And then, depending on how long Doge lasts, and then it'll have to be like value engineered at some point. There was the other article talking about this whole value engineering, value modeling, value whatever, that they're applying to healthcare, which I get. You can't go crazy town. You can't like just charge out the wazoo. At some point that it breaks, right? The model breaks, and you have to like come within reason. I just, we can't Elon Musk healthcare. I'm sorry. We can't just go in and go, nobody gets anything. We can't do that because that would be
No,
bad. People would die.
not in the US, you can't.
No.
But you're right. I mean, and certain states have done a much better job at the value-based payment system for healthcare, and it's all tied to the outcomes, and if they can truly be measured, and if physicians and other providers can be given their results and how to improve, because that's the other thing. If you don't have some assistance in how to improve, the value-based eliminates some physicians that just don't know. And so there have been states that have done it and it's worked very well. There have been other programs where it's failed miserably.
Yeah. So does it affect the amount of real estate needed? Does it do anything like that?
No, it really doesn't. None of this
stuff, right?
None of this is reducing care to the point that you don't need space. None.
Oh, okay. No. Okay. No.
This is the amount of care is there's the aging population, all those things make up the difference for any reduction in volumes. And so it's not affecting real estate space at all.
Yeah. Anytime I see value-based in healthcare, you know what I think of? I think of like the Sarah Palin death panels quote.
Right.
Right. That's what everybody thinks. It's like, oh, they're going to determine who lives and who dies.
Right. Well, thankfully, none of that ever happened.
No, none of that ever happened. But it was, I mean, basically it's what it is. It's like, are we, we make those horrible decisions about our pets almost, every couple of times you have a pet, right? I mean, a human's not a pet. I get it, y'all. I get it. I'm not saying that, but it's
if the value-based programs that are out there have wellness and preventive care, things like that, that can really help. And then you have to have physicians and other providers who understand the proper uses of various medical procedures and testing and all of that. It goes away from fee-for-service, where basically the more you do, the more you get paid. That's value-based is not that way.
Yeah. So they're hopefully doing the right thing. I mean,
exactly.
They're hopefully doing
the right thing at the right time.
Yeah, for sure. We the whole bird flu thing and the flu and any other epidemic that's happening out there, we're hoping and praying there's no COVID-20 or whatever it might be. But when you're designing a medical office building, do you have to be flexible enough to handle when you're thinking about it and the designs? I'm assuming the medical office buildings turn into the front lines for any sort of epidemics, right? They're all going to come into clinics. They're all going to come into that's going to be the first place they show up, not the emergency room.
Right. Well, it's both. The emergency room receives, I would say the emergency rooms probably are designed today better to handle the really surprise potential epidemic type patients than ever before. So they can react very quickly. They're 24/7. It could happen at any time. That's not the case in an outpatient medical building. We're not 24/7. All of that. And so, many patients, if they really are becoming ill from whatever the potential flu or epidemic that could be, they're going to go to the emergency room first. We still use the emergency rooms a lot as patients. And but now talking about outpatient medical buildings, the new buildings are being designed, and even the old ones, we are looking at how do you have areas where you can isolate in the event you need to. Now, the challenge is in a multi-tenant building, it has to be specific to each of the tenants. You can't do it in one space for the whole building.
Right.
10 different tenants. And so we have that discussion a lot depending on the specialty of how would you isolate patients that come in that you immediately identify can't be around other patients. And it's a challenge. It's a real challenge, but that is a big discussion that goes on now because we all worry about the next epidemic.
Yeah. for sure, right? I mean, you're going to build like these, stick them in these pods. Give them like someone needs to come up with like a kiosk, a sick kiosk pod with a TV and headphones, and they can sit in there, but they just can't get anybody else sick. I come up with all these cool ideas, like the Google sleeping chambers that they had at Google, where you could like put this thing over you, and you could sit in there it was like a little egg.
Well,
it was weird.
The counter to that is using various apparel stuff to cover that patient to prevent them from spreading something.
So we put them in hazmat suits?
Unfortunately, similar. Yes. Okay. Instead of having a room or a shell or a telephone booth that is only used once in 10 years or something, taking up space. Yeah. It's easier to have a closet with the appropriate apparel stuff that easily could cover the patient so that they'd be less likely to pass on something, or to cover the other patients and or staff that have not been exposed. I mean, you could go either way.
Right.
That is a quicker response than all of us putting cocoon type structures in the space.
Well, that's true. Yeah. I mean, but they got it. It's interesting. So, well, we need the sensors like Terminator, where they walk through and they like, you're sick, like go over here and get in your hazmat suit before you get anybody else sick. No,
well, there are, there's research going on to do that type of testing by what's in the air and all those kind of things.
Yeah.
We haven't implemented any of that in outpatient medical that I'm aware of. It's not affordable right now. It'd be really tough. But no. And then the other thing is, it's becoming more and more an issue about security in these buildings. So many times there is a lobby. The common space now has someone sitting in the common space who could screen for various things before people come in, like we did during COVID. That was pretty common back during COVID.
Even if you went in for a routine, I'm not sick because of COVID, they still tested you.
Exactly.
Right? Exactly. Yeah. Okay.
So, and that is very common. And we all know kind of where in a outpatient medical building we could put something in place quickly if we had to.
So when you're designing a building, then you have this like lobby, and are you putting in like air quality things in certain areas and not in others? Are you looking at?
Not at this point. Not at this point. No.
Okay. All right. Okay. Interesting. So it's all kind of similar space.
Right.
Yeah. So when you're also designing a medical office building, you're not, well, I'm assuming, because we had this conversation before, you're not pushing dirt until you've got the thing pretty much leased. So you know who the tenants are going to be and what kind of specialties they are. So you can kind of build to suit generally what they need. I'm sure they do. You give them TI money and they'll do their thing and whatever it might be. Right. But in considerations of those different specialties, obviously we talk about elevator shafts have to be bigger to get a gurney in. Depends on if it's a surgery center or whatever it might be. Between tenants, are you doing anything special to keep the spread of diseases between tenants? Like, is there like, I don't know, like those things in the ACs that knock out like all the diseases? Right. Are y'all doing things?
There's a lot of work going on right now of how to isolate airflow. In adjacent suites, things like that, so that and I think that is something that can be solved.
Yeah.
And between floors, all of those kind of things, so that anything that is airborne could be isolated and not spread throughout a building.
I think this was the one thing after COVID was all those air scrubber companies, man, they made a mint, because they were like, every university was putting air scrubbers in their HVAC systems, And I was like, how often are they changing those things? Because that's like, you're sticking them up in the ductwork, right? And you're having to go like pull out, do all this stuff to change that. Those are, they don't change themselves. And so that's kind of interesting, those air scrubbers. But yeah, they made a mint after COVID for sure. Well, I mean, are we just waiting around for the next epidemic to happen? I'm assuming.
I mean, everything I read says there will be one. Nobody knows when.
Right.
And I have been at conferences listening to the researchers who have said that one of the positives out of COVID was preparing these vaccine companies and research companies to quickly develop something for the next pandemic. It will not be, even though it was fast for COVID, it will be even much faster the next time because everything's in place. Right. And so I think there's this ongoing monitoring of what will be needed. And if truly an epidemic breaks loose, we'll have that ability. But the first wave of it, you won't have anything to protect yourself. That's how it'll be identified.
Yeah, I think it's, I hope, and I'm assuming they are spending a lot more money in detection of it, because if you can detect it quickly, right, then you can save. It's all about that. I mean, I think, who knows if they're detecting stuff quicker. They said we're like 2 strains away from the bird flu coming into humans, and they detected it in cows. Like how do they, I mean, like, so how are all of that coordination of, like, the cow got sick? Well, the farmer figured out that the cow got bird flu. Man, how on earth?
I haven't talked to the farmer. I don't know how they figured out the cow got sick, but what's important is that someone identified that. And so researchers immediately know that that's one step closer to humans, and they need to be prepared that it will potentially move the next time. So you have to believe that these researchers are ready and prepared to create a vaccine or in some way protect us.
Yeah. So when we're designing the future healthcare buildings, obviously, I mean, so hospitals are putting medical office buildings near them, right? Generally, there's like campuses or whatever sometimes. And then you've got the clinics that are serving the populations that don't have hospitals as much as you can. Is there anything else that people are thinking about as far as, I mean, we talked about the banks being turned into like testing sites, right?
So, true. And then there are certain markets where the mobile services are out there going to neighborhoods and to homes and things like that. And I think depending on whatever the need is, if there's another epidemic or something, that you will see a quicker and more rapid response than we saw with COVID. I think everybody's tuned in to what could happen, but primarily you're talking about outpatient medical buildings that can be everything but beds, basically. And then you're talking about the same thing close to hospitals. I mean, campus type stuff. But the outpatient medical buildings today away from a hospital are as sophisticated and are able to provide acute services that we haven't seen before. I mean, technology has really made the ability to put equipment in those buildings and providers to be able to do things that there's no way we could have done it 20 years ago.
Have you seen any robots?
Yes, but they would be in the ambulatory surgery settings. That's where the robots are, in the surgery, in the ORs.
Those are like not really. Well, those are robots, but they're controlled by humans, right? Not like a robot.
I have not seen the human look-alike nurse.
No.
Walking around a building or in a space at this point.
Because you would think, like, dispensing medicine, like if a robot can bring my food delivery in a hotel, you would think it can bring your medicine. It can dispense your medicine, right? Don't you think? Like if you had to get Tylenol every 3 hours, it can be the annoying nurse coming to wake you up when you're tired, and you just like leave me the F alone. I don't know. Put on a drip and then hit the button. Like leave me alone.
They may be testing something like that. I'm not aware of any hospitals doing that. And I would tell you that you got to think about this. in the pharmacy setting, given my first degree as a pharmacist, the worst thing in the world is to have dispensing and all of that turn over to robots with no pharmacists around, because then you don't need a pharmacist. And since it's a licensed type service, the licensing board controls those kinds of rules and regulations to not allow.
Yeah.
And so, no, there's a limit to. We've always had dispensing machines that would help count things and all that kind of stuff. But to go full force into robots, I think will be a while.
Okay. I was like, well, maybe the food then. It can do the food delivery.
Delivery of food, the little robots that roll up to your table or run around the campus with stuff in a box, or the drones that drop it somewhere. That all
That's easy, right? Not medicine. Not medicine. Yeah. Okay. I gotcha. You never know. Change out your IV bag. You never know. I'm just kidding. Totally. So when we have the other article I was talking about, when they're talking about predictions of stuff happening in 2025, I love predictions. Predictions are great because nobody knows, but they're guessing. The one thing that they were talking about, I guess, is obviously we've talked about this before, right? The last baby boomer turned 65. They turned 65 this year, right? The last baby boomers are turning 65. And we've been talking about epidemics. And so we have this population that needs, my dad's 82. He just turned 82. He's turning 82 tomorrow. Happy birthday, Dad. So is the consideration around what's happening, obviously, in the government, what they're trying to do with Medicare, Medicaid, this whole value-based outcomes for that kind of thing. Can we somehow sustain that? Like, is there, I guess my question is, do we have enough medical office buildings? Do we have enough infrastructure hospital-wise to handle if all the baby boomers started getting sick? Like, do you know?
If they all, or a high proportion, got sick and needed to be in a bed, no, we do not. That is why you saw, even during COVID, almost the National Guard bringing out these mobile hospital setups, because we needed the beds to take care of those patients because hospitals filled up. We don't. If it is another mass epidemic impacting 65 and older, we will have a real challenge for the number of beds in traditional hospitals. But I think what will happen is very similar to what happened in COVID. There will be the makeshift hospitals that the military is well equipped to do. And I don't think we will be putting up beds in the Superdome or something like that. I just don't see that happening. It doesn't lend itself to medical care. But and I don't know how much warehousing has been done, but I would imagine there has been significant warehousing of that type of mobile hospital stuff in the event for the next one.
Interesting. Yeah.
That's how you do that. You couldn't build enough beds because you couldn't afford them, because most of them are going to sit vacant until the pandemic or the epidemic occurs.
Yeah. What is the, if you're going to say the bed occupancy rate, like on a normal day in America, is it like, are they half filled? Are they like a quarter filled? Like, do you know? I ask you all these weird questions, Deanie. Like, I'm going to come on this show. Amy's going to ask me these weird questions.
Hospitals, first of all, hospitals are really challenged if they're over 90% occupied, because it's almost like a hotel where they need the time to turn patients in and out. You really don't want to be 100%.
Right.
Because you can't manage where the patient's coming and going, because you can't get them in and out fast enough. So I would tell you 70 to 80% occupancy is manageable.
Okay.
But now, is that the average? I don't. I'd have to look it up. I don't know. It's also seasonal. Like right now, many hospitals are full. It's flu season. It's all of those kind of things. And then it's market specific. I mean, you could have rural hospitals that may not have 30 or 40% occupancy. So it just depends. But I would tell you, you don't want to it's not sustainable when you get up 98, 100%, because it really is difficult to move patients in and out of the building when you get to those numbers.
So do the hospitals talk? Like if there's an epidemic and they're full and they'll go to other,
then they put out an alert that they are on bypass. And so ambulances don't come to that hospital. They know where to go because that hospital's full.
Yeah.
Now, if that hospital has unique services, if it's a trauma hospital, things like that, they still take patients.
So
they may keep patients in the emergency room, or they may put them in an ambulatory surgery setting in the hospital until a bed is available.
Oh, interesting. Okay. And so, so managing all of that, like trying to figure out, I'm assuming that's a great use case for AI, but you don't really know until, they don't know. They're reacting as something hits their door. They don't know what's walking through that door, right? And so they always have to be, prepared for the worst on most occasions, I would assume.
Right. And the other piece of this, which is as important, if not more important, it's not about just about the space. It's about the number of staff that are going to be there to take care of this.
Right. Yeah.
I mean, there is a limit. And if the patients just keep coming, you can't just keep adding staff. There may not be staff available.
Yeah. It's robot nurses again. We need robot nurses. Totally kidding.
We're a long way from that.
We are a long way from robot nurses. I know. But
I won't be on this show. I can tell you when robot nurses come.
Oh yeah, robot. Hey, you never know. We could get the Mandalorian robot with the spray that heals you. Hey, I'm okay with Mandalorian robot.
Okay.
Person. So we have. But they are figuring out ways to use smart things like check-in kiosks and different ways to do things to take, initial, and I'm assuming
they triage the patients so that they can identify those patients that truly need care in that setting versus those that could go to an urgent care clinic or go home and a nurse practitioner talk to them by phone or something. Yes, that triage now is standard. That wasn't the case 20 years ago.
Right.
We didn't have that, but we didn't.
Yeah, for sure. I'm wondering if before it even hits the door, if there's something coming out that's saying, hey, don't go to the ER for this, go over here.
If you call, many of the health insurances will encourage you to call their number, which is usually a nurse practitioner or a specialty nurse of some sort, who will tell you this is something you should go, or no, you could do X, Y, and Z and try this at home. And you may not need to go to the emergency room. Yes, there are services that will give you that information.
People even pay attention. I just want to ask my phone. I can't think of calling my health insurance. I just need to ask Siri. Siri, never know. Okay, so what markets are you obviously the Sun Belt where people are migrating to, all of those great things. Have you heard about anything happening? Obviously, North Carolina has to rebuild. There is they have a lot of, the hurricane just basically blew through North Carolina and leveled.
There are a lot of medical facilities up there that have been damaged, and they will rebuild.
Yeah, interesting. So, are the time to do something like that? So are they in tents? How are they handling?
No, I don't think they're in tents. They may be in other building types that are not ideal at this point. But
it's interesting. And then I'm assuming in LA and the fires, it's the same way, right?
Same way. There've been real destruction of medical facilities, and so those get relocated. It causes a real problem if they're not as convenient, obviously, and people have to travel to them. But no, they've been relocated.
So the life science labs that are basically vacant, could they be repurposed into a medical office building?
They could. The challenge is the cost. These buildings are much more expensive, and the tenant improvement for that lab space is much more expensive. So if you're going to do it, you're going to have to recognize there is a major loss of that building converting to medical. That's the challenge. Whoever owns that building is going to take a significant loss, and it's just a matter of, do they wait and see if the tenant does come that would use it as intended, or do they take a loss and let that facility change? It's still going to be costly to turn it into clinic space, lab space.
Yeah.
But you have a better chance of doing that than in a commercial office building.
Yeah, that's true.
Yeah.
That's true. And they have lab space there, so they can do their own labs.
Well, yeah, it's an overkill for the kind of lab space you need.
That's true. That's true. You know,
but no, the systems in place are more in line toward medical than a commercial office building.
Okay. All right. So if that
the challenge is the cost that's been incurred to put that building up.
Well, for sure, right? I mean, they took a gamble. They were chasing the shiny object and started building, like anything. Like it's, you know, like everybody wants to be a data center owner now. You know, they don't know what they're doing, but you know, they're going to try. You know, it's like you get money chases lots of things. So life science was hot. Like it was hot. Like it was like the thing. It was. And I was amazed at
now it's overbuilt.
Now it is. Yeah. Yeah. I don't know. It is for sure. So we have a couple more stories, and I was talking about, let's see, what was the last one I want to talk about? Oh, and I don't even know if this is really a true story. It seems like it is, but maybe I don't even know if I even sent this one to you. But what is evidence-based design? And it's talking about the process of constructing a building on scientific research for the best possible outcomes. Oh, I didn't send you that story, did I?
No, I haven't read that.
Yeah.
Sounds like to me an architect trying to support the services they provide.
Yeah. Sounds like they're value engineering the design, which is okay. You know,
that I don't have any issue with that. I understand.
Yeah.
But
it's a new phrase, or maybe it's an old phrase they're resurfacing. It's just so maybe it's a marketing gimmick. Who knows? I don't know. I mean, duh, right? Everybody's designing their buildings for the best possible outcome. I mean, like that's like what do you call that? Like a Captain Obvious. What is the phrase? I don't know. I give up. But if we're thinking about repurposing buildings, and on that same vein, right, like life science labs to medical office, when you're designing a medical office building, and you already know what tenants are coming in, but generally the tenants aren't going to need major changes, or do they?
Right. No, here's right? It depends on the use. For example, if one of the tenants is an ambulatory surgery center, that to convert that to clinic space is pretty costly because it wasn't designed that way. It can be done, and it's done often if that surgery center goes out of business. But if a medical office building is all clinic space, it's pretty easy to switch from one specialty to the other because you're talking about exam rooms. Typically, exam rooms don't need to change unless it's a very unique specialty. Now, if a dentist wants that space, an exam room doesn't work. It needs to be repurposed. You may have to take 2 exam rooms to make it one where there's room for a chair and all the things that a dentist needs if you're going to put a dentist in there. But if you're switching from a cardiologist to a family practice or back and forth, those exam rooms are about the same. The other thing that's changed is most of the physicians now don't have their own offices. So, physician offices need to be converted to exam rooms. So you may not have the access to water and all the things in there and sinks and stuff. So you have to replumb that space, things like that. I mean, but it's easy to do. That's not true of converting commercial office to medical or those kind of things.
True. There was a story out talking about how because every state has basically legalized sports betting, that there's a bunch of gambling and addiction now. And so behavioral office space. So does behavioral office space follow the same as medical office, or is it different? Like if you had a
Oh no, there's a real demand for outpatient behavioral health space, and and it has a better chance of using commercial office than your traditional outpatient medical, because they don't need all of the various services, meaning utilities and all of those kind of things in a behavioral health space. And so that is one use of commercial office right now, is using it for behavioral health.
Interesting.
Yeah.
So
I didn't know. I'm gambling's only one reason for that growth.
No, there's a lot. There's a lot. My grandmother, bless her soul, when she was a psych nurse, and so she went back. Actually, she got her nursing degree when she was 55. She was a year older than me and got her nursing degree. She went back to school and got her nursing degree. It's a great story. And then she worked for the next 30 years as a psych nurse. Wow. I know. And I was just like, and I don't know what drew that to her, that she's going to work with people. But bless her, because there's people that need help, right? And they're dealing with lots of different things, right? But in those settings, it was more, when I remember visiting her, those were more like hospitals than.
Yeah, that was probably an inpatient behavioral health, where it would be more like a hospital, where there are beds and there may be a unit that's locked and all those kind of things. But in the outpatient setting, they tend to be there for long periods of time, but they don't spend the night. There's no need.
Yeah, that's true. Okay. All right. That's interesting. So just your typical social worker or therapist or
meeting space. There's things that go on that are more in an office than in an exam room, things like that.
Yeah. Okay. So that's a behavioral health that they're referring to.
Exactly.
Okay. Interesting. So, all right. What do you pick? This is the time. Pull out your crystal ball, Deanie. Besides Doge or the silver tsunami, or what is the big trend or the big thing that impacts healthcare real estate this year? What do you think is the big one?
You know, I wasn't too worried about this before, but I would tell you, we are seeing the worry of the reduction in research funds. Health systems and universities that are doing research, all of that is having an impact on life science for sure. Okay. But it's also starting to have an impact on medical office development at the university academic centers, where they are worried, how will research be funded, and do they need to prioritize something to help that? And so a new medical building may not be what's in the cards. And so we're watching that close.
Yeah. This is, you're referring to the thing where they only can do 15% overhead, right? Yeah. Yeah. Okay.
Because rent is in that number.
Overhead.
And if you remember, it's all about the rent.
Yeah, it is. It is for sure. So interesting. Yeah. Okay.
I think that is something we are watching. The second thing is, most buildings are, it's got a lot of steel. And so we're all watching to see what happens to construction costs with tariffs.
That's true too. Yeah. Well, I think a lot of I did a thing. I think a lot of our steel comes from Canada and Mexico, right? Not so much China. So hopefully our neighbors can deal with the president, and, we can figure it out. I don't know. There was an interesting article about the president of Mexico and about how she's handling Trump, and other leaders are looking at how the Mexican president is handling Trump, and, kind of negotiating her way through. It was really kind of interesting article, because there's this saying in Mexico that whoever gets angry loses.
Oh,
right? So she's being very calm. She's very like this. She's doing, you know, she's just not losing her cool. And they're taking a page from her book, and she's negotiating through, and she's figuring stuff out, and she's giving what she needs to give. And I'm just like going, huh, interesting.
how about that?
Yeah, how about that?
Yeah.
Yeah. Just
But-
don't rant and rave like he does, and just kind of keep it cool and
Yep.
see what happens. But yeah, it's interesting. I'm not sure what the game is. I mean, there's a game afoot here, and I haven't figured out all the pieces and what's happening, but something's happening. And but I can't imagine. I don't know. I mean, I can't imagine that we would want to suffer too long with these tariffs, right? If it's going to hinder.
I hope not, because I mean we go the other direction potentially on interest rates and everything else, and we really don't need that.
No, I mean, real estate's already taken enough hits. I mean, we've had the interest rate thing where we can't get loans, our inflation's killing us, and now you're going to do tariffs too? Seriously? I think today every real estate developer wants to punch him in the face. Like, come on, man. We were just had this survive till 25. Like, we just needed to get through inflation. We needed to get through the interest rate. Jerome Powell gave us a lifeline. He cut it twice. Like, you know, like, come on. Now you're doing tariffs?
Exactly.
Really?
I just worry. I just hope that they don't get into a situation and have to raise rates.
I know, right? And that would just be a bummer. That'd be a total bummer.
That's
all right. We're at the end. Look at that. Our hour is up. Well, if people would like to get a hold of you because they want to invest in medical office buildings or whatever it might be, how could they do so, Mr. Taylor?
They can go to our website, Landmark Healthcare.
There you go. Landmark Healthcare. That's it.
Just go to our website and we can address anything they need
in
the outpatient medical world.
Yes, exactly.
All right.
Well, thanks for coming on the show. It's been fun. We'll see you. Well, that's been the show, y'all. Another commercial real estate morning news show and healthcare with my pal, Deanie Taylor. If you are interested in anything that Landmark Healthcare does, please reach out to Deanie. This is a show of the U.S. PropTech Council. And like I said at the beginning of the show, we are having our event at South by Southwest this year on March the 9th. Look for the tickets on our website, proptechcouncil.com. And I will see you Thursday for our multifamily show and the data center news show. We'll see y'all. Have a good one.